Belinda, by the way, her team works in the hospital as well as out of the hospital. On any given day, they'll have 30 to 40 outpatient visits they need to make. So she is a busy, busy lady.
That's on a quiet day.
That's on a quiet day.
Good morning, everyone. It's still morning. It's not quite lunch yet. My name is Belinda, and I'm actually going to speak to you guys about physical therapy, occupational, and speech therapy. So we've got all three disciplines, and we do inpatient therapy and outpatient therapy. I think you guys all got the handout. Did they get the handouts that we sent?
No, I got it right here for you, and then it's going to print it out for them.
Okay, all right.
Put it under this one here. This is your...
Can I control it with this, with the arrow, because I'm not good at it?
Probably can. Yeah, it's the same. Yeah. It's thinking. It's payroll Monday, folks. Our computers are busy.
Because I have pictures. I like pictures, and I will keep everyone awake. All right. So basically, the first part, I'm going to focus a lot on the acute therapy, what we do in the hospital, because I know you probably, if you're going to go visit people, will be the patients that's in the hospital. So that will make more sense. If anyone has questions about the therapy services we do, that's where you'll have questions about. And then in between, if I say anything that doesn't make sense or anything that you wonder about, just put up your hand and ask me questions in between. Okay? All right, so the acute therapy, like I said, is what we do during the hospital stay, and our focus there is to kind of help nursing and the physicians and case management to decide what is going to be the best place for this patient to go when they leave the hospital. So we might not do very intense therapy like you might see when somebody's in a rehab hospital or when they're an outpatient. A lot of what we do in the hospital is evaluating the patients. We see them maybe the same day they had surgery, or we see them the next day of surgery. And we immediately start working them to do some simple things that we take for granted. You know, just getting out of the bed, sitting up on the side of the bed, maybe walking to the bathroom. Very, very simple, basic things that's difficult right after you had a new knee or a new hip or you had back surgery. So that's the kind of things we'll do. And then really focusing on seeing what will be the best place. Does this patient need to go to a nursing home for rehab? Can they go to a rehab facility? Can they actually go home? Do they have enough support systems at home so they can get somebody to come and do a home health services? Or are they good enough to just go home and come back and get outpatient therapy? So that's really a big part of what we do in inpatient therapy. So we also do therapy services, not us necessarily, but like I said, you can get it in nursing homes, home health, and the goals will very much depend on the setting. So if you're visiting with a patient and they say, well, you know, therapy was in, they worked with me for about 20 minutes or half an hour, it's not because, you know, the patient probably could only tolerate that at this point because they're very sick when they're in the hospital. But when they get to a rehab facility, they might get 3 hours of therapy, 1 hour of OT, 1 hour of PT, 1 hour of speech. So that's just something, if somebody questions that, so you would know it's not that we're avoiding seeing the patient, that's just because of the level of care where they're at. So skilled services, sometimes people would say, well, such and such needs therapy because they need to be able to walk down the hallway. If it's nothing that requires a skilled therapist, that is something that nursing would do with a patient. So if somebody had just come in for like a, say a gallbladder surgery or something that's a routine surgery and you're expecting they're going to struggle because they're in pain, those kind of patients necessarily don't need rehab. But somebody who comes in and they had a stroke and they were still driving, going shopping, you know, doing their own things the day before, now today they're paralyzed, those are the kind of patients that actually need skilled therapy because it's not just a temporary medical thing that's happened to them that's needing to maybe need a little bit of assistance. So even somebody who comes in who has a baby, you know, we don't need to go in there and get them up right after. You know, it might be difficult for them to walk and get up and move and get out of the bed, and nursing will work with them on that because that's kind of a routine thing that you're kind of expecting. But anything that's skilled is something that needs specific goals to kind of get the patient to get better. So that's kind of a way to explain it, because it gets very gray if you see the therapist, working with a patient, they've got a walker, and then you see, a nurse working with a patient and doing a similar kind of activity. But it's basically the skill level, and we are upgrading. Maybe today we can only walk 2 feet, the next time we build up to 10 feet, then we go from a walker to a cane. So it's all those kind of things that we speak about when we say skilled, because it needs a therapist's judgment to decide what is the best device or the best goal for that patient. And then for a patient to get therapy, they need to be able to improve, and it needs to be a reasonable outcome that we're expecting. So if somebody comes in and say they're not able to respond to our instructions, they might not be able to walk or do things for themselves like they did before, but they can't respond to any instructions, or they're not able to learn because of maybe they are just at a level where they're not, a level of arousal where they're not able to follow instructions. So even though you might see the patient and think, oh, they really need therapy, but if they can't follow directions yet, we're not going to be able to teach them to get better. So that's why there's a little bit of gray areas, and it's hard to determine, do they need it now or when, and that's where the therapy comes in, where we can make that decision. And then for any patient to see therapy, just because they're in a hospital, we don't go up to all the patients and start treating them. They need a physician referral. So even outpatients, sometimes we get people calling saying, well, I need this and this, can I just come in? No, they need a physician referral. So that might be a question that might come up that they might ask one of you. That's just, I threw in a couple pictures so you guys can visualize. I don't know if you're going to get to go on a tour at all, but that's our inpatient therapy area. It looks a little different now. We've added a couple extra equipment since we've taken that picture, but it's on the 4th floor, and that's basically, most of our patients we might see bedside. Like if you think about it, if somebody's in ICU, we're not going to take them out of there and take them up to the 4th floor. On the PCU floor, medical floors, we see them right at the bedside, but on the orthopedic floor, maybe the first day we'll see them in their room and just kind of get them to walk to the bathroom, walk to the door, but then the goal is eventually to get them into the therapy gym. So by the 2nd or 3rd day, that's where they'll go in and work in the parallel bars. Before they go home, they might do steps if they're going straight home. A lot of people have steps to get in and out of their house. We even have a car, and I don't think there's a picture in here, where we can practice a car transfer. So if you ever get to go up to our 4th floor, peek in there and take a look at it. So unskilled services, I touched a little bit on this already, is anything that's general maintenance. People might need help to feed themselves, but that's just their level where they're at. It's just a maintenance thing. So that's somebody who doesn't really require therapy because they need that assistance. Maybe they need help with dressing, transferring, or anything that's a general maintenance. Or somebody who just needs to sit out of the bed, anything like that. Passive range of motion, just moving their arms and stuff. Once we sometimes in ICU see a patient and the family members are always there supporting, we'll teach them. It helps them to feel like they're contributing to their loved ones' well-being, but at the same time, because it's maintenance, it's something that has to just happen every day, so we include them, but we don't have to have a therapist to go back and do that, which is different than somebody who had surgery, because you need the skill to know how far you can push, how many degrees you can, so that's where the difference is, again, between skilled. Anything, like I said earlier, that's transient, that's going to reverse without our professional skills. Anybody who's at a baseline level of function. So say somebody comes in and they were a paraplegic and they were in a wheelchair and that's the way they got around. Or they needed help to get in and out of the bed, or they needed a wire lift at home. Just because they're in the hospital, we're not going to teach them, to where they needed a wire lift, where they're now going to do it on their own by after 2-3 days being in the hospital. So anybody who's at a previous level of function, they're not going to need to see us. And then anybody, like I said earlier, who can't really demonstrate new learning. So anyone who's dementia, combative, disorientated, or sedated, where they can't retain anything that we teach them, or not able to follow commands. So those are kind of the things that, wouldn't be patients that's appropriate for therapy. That's just a couple more pictures, just showing us why does it move on its own? You know, how we would, those are therapists, so we didn't have patients on there, but just practicing the steps, walking in the parallel bars, and then stretching the knee after knee surgery. All right. Now, nursing sometimes will call on therapy to come in and screen a patient, and that's perfectly fine, and we'll come in. I don't know why this keeps jumping. I know, maybe it's set up on a slideshow or something, because I'm not touching it. All right, so sometimes they might not be sure, and the doctor hasn't ordered therapy to come in yet, but they want to make sure the patient doesn't maybe miss out on therapy if they think this is somebody who's one of those gray areas. So they might ask us to come in. We can't really touch a patient or do anything with them when they ask us to come screen a patient. So if you're speaking to them and they say therapy came in and they, you know, just spoke to me or they spoke to my family, and that was probably a screen that we did. So we can't physically even touch a patient or move them unless we have a physician's order to see them. So speech therapy will be needed if anyone has a change in communication or swallowing. If they have difficulty to swallow after like a stroke. And in occupational therapy is, we focus a lot on the upper extremities. So anybody who had a change in, you know, they might have had shoulder surgery. Some people are smiling because they had it. Shoulder surgery, or anybody who had a stroke and they can't use their arm. Anything like that, that's where occupational therapy will come in, because occupational therapy focus a lot on, we're not going to find the person a job, even though occupation sounds like it. Occupation refers to any activity that we have to do, dressing, bathing, anything like that. And in physical therapy is if anybody had a change in how they mobilize or they function, strength, or if they're at risk for falls. So that's a lot of the patients we see. So that's just what we do on the screen. And I think I covered that a little bit already. This is just kind of a decision tree, and I know you guys will get a handout. And this will probably kind of, it's on one sheet, capture everything that I've said on how we decide if somebody needs therapy or not. So if somebody's at a baseline of function, we're not going to do therapy. If they're at the highest level we think they're going to be by discharge, they're not going to need therapy. But if a patient has prognosis to get better, then yes, we're definitely going to do therapy. If their prognosis are like, well, they're probably not going to get better, so, you know, then they don't need therapy. But sometimes we'll see them for 1 or 2 visits if there's a family member that needs to be taught to do some of the passive range or some of the maintenance stuff. So this is a good tree to kind of reference, and it just kind of shows how we make our decision. Yes, no, are we going to be doing the therapy? And then this is just a nice comprehensive list as well, like positioning a patient. That's kind of unskilled. We might come in the first time and show what is appropriate to do, how can you position a stroke patient so they're aware of both sides. But then the daily positioning becomes like something that nursing would do or the families will do at home. Developing an exercise program, that's a skilled therapy. But once they learn it and they can do it on their own, they don't need to come and see us. So it's just that skill of getting them started, getting them trained. Bed mobility, getting somebody just in and out of bed is not skilled, but teaching a patient to where they can do it independently, that is therapy for us. Just getting a patient to the bedside commode because they need to use the commode is not skilled therapy, but teaching a patient how they're going to do that on their own, that will be skilled therapy for us. So once you start thinking about it, it kind of makes sense, but sometimes, like I said, it is a little bit of a gray area. Walking the patient down the hallway and stuff, that's unskilled. But if a patient needs practice or training in a device because they never had crutches and now they have to work with crutches, now they need to learn how to use a walker, that is skilled therapy. And in communication training, and we work very closely, I know you just had a presentation from the dietitian, we work very closely in speech therapy with the dietitians because my speech therapist would make the evaluation to see, can the patient swallow, can they do solids, puree, what kind of diet can they tolerate because of the mechanics of their swallow, and then work very closely with dietary to make sure they get the correct diet. So, and then we have a close relationship with radiology as well because that's where we do the swallow testing, and we can see how they actually, with the x-ray, we'll see how they swallow. So again, that's a good reference sheet for later on. That's just, sometimes a patient would be, there it goes again. I don't know, something magical here. Maybe every time I move, it moves as well. Sometimes you'll see a patient, maybe you'll go and speak to somebody and they said, you know, they were on the medical floor as an example, and they said, well, therapy was here, they were working with me, and say now when you're visiting them, they're in ICU. And I haven't seen them yet. If a patient goes to where they at a higher level of care, kind of going back to ICU, they need to get new orders for us to see them because they kind of decline. That's where they went from a regular floor to ICU. So we need to make sure they're actually safe to continue with therapy because we do a lot of things with them. So we don't want to jeopardize their safety. But if a patient goes from ICU and they go to medical and they go to one of the other floors, we'll just keep on seeing them because they progress medically as well. So, you know, so that might be something that somebody might say, well, I haven't seen a therapist for the last 2 days, but then that will be something that you can say, well, that's, you know, we'll tell them, but, you know, patients get so much information, so that will be a way for you to know why we're waiting on the physician to give us new orders, or maybe the patient is not stable enough to tolerate therapy at that point. So there's a lot of coordination every day going on to make sure that we got orders on people we needed to get new orders. So there's a lot of behind the scenes juggling to actually then treat the patient that we have to do. And then even if somebody goes in for a procedure, in and outpatients, if somebody was on therapy and then they get into the hospital, and then they come back for therapy, and even if it wasn't related to what we're working with, they need to get clearance that it's okay for them to continue, because they may be in for a shoulder, but they got admitted because they had chest pain. We want to make sure they're safe to do the things that we're going to be doing, because we might use weights, and you know, there might be specific precautions that you need to be aware of. And that's sometimes hard for people to understand, because they're like, well, I'm already in therapy, why do I need something else now? But it's because there was a change during the time they had therapy. And then sometimes if we're still waiting on the orthopedic to come and see, make sure there's a fracture, anything like that, or they're having a DVT or anything like that, you know, we'll place them on hold to make sure that, because the patient's safety comes first, you know. We do want to give them the therapy, but we don't want to do anything that's going to jeopardize them. We don't want to walk anyone if they might have a fracture that's not fully diagnosed yet, because sometimes they come in and they're still going to go through the x-rays and the scans and everything like that, and already the order starts coming in, and we don't want to jeopardize anything. So that's an example of what we do in outpatient. Pretty much spoke a lot about inpatients. That's just some of our weight equipment. We do people with sports injuries, people after surgery, total joints, orthopedic. That shows some of our other equipment. I don't know if the picture's 100% clear. That's a Biodex machine. I don't know why it does this. There must be a timer that's set up in the slideshow. That's one of our Biodex machines. It shows somebody working on a knee, but you can pretty much do any joint on that machine. And instead of, like in the past, we would test people's muscle strength manually. So somebody would keep their arm, and I would say, I'm pushing down on you, don't let me push you down. And then we have a scale how we determine is it a 1, 2, 3, or 5. But with this machine, you can actually let them move this device, and it will give us a more objective measurement on how much they're pushing. So it's much better for the physicians to see, and it's more accurate, and it's smaller increments of improvements that we can measure. And it's much more motivating for the patient to see, because sometimes like going from a 3 to a 4 doesn't make a whole lot of sense for the patient, but if they can look on the computer screen and see, oh, I pushed up to there and now I'm pushing here, they can visualize the improvement. It makes a big difference for those patients. And you can set it up, people make fun, they say it looks like a dentist chair, but you can set it up to work out from the wrist to the hip, to the ankle, every body part on that machine. So that's a really nice piece of equipment that we got. That's one of our balance equipment, and Joy actually was there with the patient. She is certified in vestibular rehab. Not many therapists do that. So that's for people who experience dizziness, when they at risk for falls. It could be very detrimental for a lot of patients when the world just starts spinning. I don't know if anyone here ever had that vestibular disorder, and it is not something that's comfortable. It makes you sick, you feel nauseous, you just feel like you want to cover your eyes, you don't want to see anything. And it can sometimes just come on. So she's specialized in how to work with those patients, and she's helped a lot of people with that. So that's one of the machines we might use in therapy. And the base where the patient is standing on actually moves. And then, I don't know if you can see the little screen on top, it's also kind of like a virtual reality. You're a little dot there, and you have to keep yourself, and that works on your balance as well. And then we also do wheelchair assessments. So if you come across anyone who's like, I need a wheelchair, but they wanted me to get an evaluation, we do those in outpatient as well. That's our HydroTrack. It's an underwater treadmill. There it goes again. Underwater treadmill. It's heated. It's like a spa. It's got jets in it, so it gives resistance to work out in. And for a lot of patients after knee or hip surgery, back surgery, and it's difficult for them to work out on land on a regular treadmill, that's a great tool that we can use in outpatients. Naturally, it has to be somebody with the wounds and everything has closed already. And, you know, it's just like a regular spa with all the chemicals and everything in there. So we clean it out once, you know, a lot of people ask, do you clean out the water every time somebody gets in? But it is like a spa, and then we clean it out once a week, but it's got all the chemicals and everything in like a spa. So that's a nice addition. Not many places in this area has that either, so we're very lucky with our equipment. That shows just some of the things we would do in hand and upper body rehab. The top picture is somebody who's got, sometimes we use certain tools where we can use medication. Instead of a patient getting an injection to work on the tendinitis or inflammation, we can apply it using electrodes. There's different machines we can use. That's actually just one that we can pull off. So you put it on with the medication, and the patient can leave wear it for 24 hours. So they get the benefit over a period of time after, even after leaving therapy. The bottom picture is just, and I don't think you can see it very well, but it's somebody who had a contracture and we made a splint. I think you only see the straps from the top there. But we do make custom hand splints for patients, because if you just look at people around you, their hands, everyone has different sizes and shapes and everything. So it's very difficult when you need a hand brace after surgery to get something that you buy in Walmart. Those are okay because they're small, medium, large. But if you need something custom that's going to stretch a joint or be specific, that's where therapy comes in, and we can make them. And it's a low temperature plastic, so it's not like the prosthetics that somebody would make. Those are moldable, and we do it right in the therapy center as well. We do a lot of education. That's one of our therapists, Celeste, teaching back school. So we do education classes, not just for patients, but also actually for employees, because we want to make sure our employees are safe when they work with patients and transfer patients. And then that's just some more pictures showing some of the tools we might use to test somebody's strength, look at their motion, and that's just some of our tricks we've got to work on people's motion after somebody broke their wrist or their arm. That's just some of the things we'll utilize. We do a lot of hands-on therapy. That's the part where the patients kind of don't like us so much anymore when we start stretching them. But it's a necessary thing we have to do. And then that just shows another kind of a brace. That's somebody who had a Dupuytren's release. I wish I can get this to stay. Dupuytren's release. So it's somebody who's maybe their finger was pulled up for a period of time. And typically it happens over time. It's the fascia that shortens, and then they just, start struggling. They can't get their hands in their pockets, can't get the change out, and then it becomes annoying, and then they'll go to the physician, and then they release the fascia, but the therapy part, they start the day after surgery in therapy. And our focus is to make sure we maintain what they get in surgery. So that's just one of the braces we might make for them. And then that's just our team. So you'll have our phone number and everything on there, because I think I bumped into a couple people since we started wearing our uniform. People were like, I didn't realize you have outpatient therapy at the hospital as well, just because everyone visits the inpatient, so people are aware of it. But we do have outpatients in the Cypress Physicians building.
Question, after the doctor ordered therapy, for what length of time that is, do you have what possibly call like a wellness program where the patient could keep coming back?
Yes, we do. We actually have some pictures that's going to come up. We have, for the people, because we don't have a very, very big variety of equipment, so anybody who's been a patient of us, they can sign up for the wellness, and it's, if you've been a patient, it's like $15 a month, so it's not a lot. So most patients, they'll come maybe for 2-3 months after they finish with us, because that's a motivation. I mean, that's kind of the way I am. I'm not going to work out at home, but if I go somewhere and work out, I'll do it. And that's for some patients. Some people are good. When you teach them, they'll keep it up at home and they do really well. But for some people, they want, you know, and they might feel intimidated to go to a health club. So it's like a safe place. They have questions, we're right there, they can ask us. So hopefully as we get more space, we can expand it a little bit. Unfortunately, right now, it's only for people who's been therapy patients. So even if they've been in a hospital, we're not able to really accommodate them. They had to be outpatient therapy patients. But, and they can even bring a buddy if they want to. The cost is a little different, but there's some of the pictures. Actually, the picture on the right is one of our wellness patients. And I think that's it. That's all my pictures I had. So I didn't know if anyone had specific questions you were wondering about, or questions that you might have had as you visited with patients.
It's a great program.
Thank you very much.
By the way, Belinda's going to be having part of the Mediplex building?
Yes, we're actually going to add cardiac rehab. That's a service line we haven't had for a long time. We haven't had it ever, and we've had a lot of calls, people asking for it, and you know, we have to send them out of the area. So that's going to be a nice addition. So we'll still be in the Cypress building, the PT and OT and speech, and we're actually getting a little extra space there, so that's a good thing. But the cardiac rehab is going to be in that building. So that will be something to look forward to for this area. All right. Well, thank you for your time. Yeah.
Good to see you.